Hello everyone, this is Alraies from SCAI 2022 in Atlanta. With me is Dr. Kenneth Rosenfield. He is from Mass General and he has been an expert on venous system as well as pulmonary embolism. Ken, thanks for being with us.
Thanks, Chadi. Thanks for having me. Oh, thanks. Actually, PERT is all about multidisciplinary team-based approach as opposed to owned by cardiology. Actually, the entire concept is that pulmonary embolism is an area where we have a huge evidence gap, and we don't really understand the very best treatments for patients. And frankly, it's owned by everybody. Cardiology, radiology, vascular surgery, vascular medicine, interventional radiology, emergency department, pulmonology, critical care, and cardiac surgery. All of these specialties and then some have something to say about it. Hematology, I left them out. I mean, that's the point, is that in different institutions and around the world and within the U.S., PE is managed by a whole array of different specialists. And PERT, the concept of PERT is to bring together all these specialists and try to figure out by consensus what's the best treatment for an individual patient who comes in with an acute PE.
Yeah. And you are on the board of been a pioneer from the beginning. So what is new things we have to move in and to help these patients?
Yeah, well, we have lots of new innovative treatments. Obviously, thrombectomy world is exploding, and there's been a lot of investment in that community and a lot of interest amongst the interventional community in doing catheter-directed therapies, whether that's with lysis, using ECOS device or the Thrombolex device, which is a new device, or using thrombectomy with an Alraies approved device, Penumbra's device, and then many others coming down the road like Truvic and so many others actually. So the challenge is to figure out what's the right treatment for any individual patient, and whether a patient deserves advanced therapy with one of these novel approaches, or whether conservative therapy with anticoagulation alone is sufficient. So that's the trick, and we don't have the data, the evidence base right now to establish what is the best therapy for an individual patient, and so that's the challenge for us, and we need to develop the evidence base that will help us, just like there is in acute coronary disease and acute stroke.
Right. And one of the challenges, like I'm going through it in my institution, is the PERT consortium have guidelines and algorithms, but not always applicable to everybody, because as you said, different players, IR, ED, pulmonary, critical care, versus somebody who has vascular as well involved or not. So these are kind of fine-tuning items need to be addressed locally, but definitely the road of the map can be taken from the PERT consortium.
Yeah, I think that well, the algorithms are established. They're all basically a level of evidence C, which is to say that we don't have very many class 1 indications for things. And that's the reason for the consensus approach. Now, you're right that every institution has different people making up their team. From my standpoint, as one of the founders of PERT, the importance is that you have more than just one person deciding things, because there's no feedback, no sort of checks and balances. And I think that in the absence of an evidence base, it's important to have those checks and balances and to collect the data to ensure that you're following these patients long term and tracking outcomes so that we can actually learn from that.
Absolutely. So far there's a couple of trials going, and we have trials before Seattle and others. We have a couple of trials coming now, and hopefully that will answer some of the answers that you just mentioned.
Yes, I mean I'm privileged to be the co-PI of the HiPytho trial, which is randomizing patients with high intermediate risk PE between anticoagulation versus treatment with catheter-directed thrombolysis using ultrasound-facilitated device. But there are other trials. There's Strike PE, which is looking at the use of the Penumbra device. There's the Inari trials that are underway, and all these are going to help contribute to this data gap to fill this data gap that we have. We just had a really cool meeting that we set up. The PERT consortium sponsored and led this meeting with the FDA, who is keenly interested in the PERT consortium's database and the acquisition of additional data. And this meeting was called PERT. It was the Pulmonary Embolism Research Collaborative. It was an invited meeting that we held in Washington with about 100 people, and we had 19 or 20 FDA participants actively involved in this thing. They are incredibly engaged. And the idea was to come up with, to broaden the scope of, of elements that we're looking at. Are we really looking at the right things? RV-LV ratio, clot burden, vital signs, and so on. What are the things that we should be looking at to be able to inform us about whether we're making the right decision? So this is the direction. This is there was a scope of our project, and it's just getting underway. So we're going to be revising the PERT database over the summer, and working with the FDA to establish a series of data elements and their consistent definitions, so they're standardized from trial to trial and from database to database, so that we're looking at apples and apples versus apples and oranges. And hopefully at the end of 2 or 3 years, when we accumulate data, this broader scope of data, then we'll be able to answer some of the questions that you just asked about what's the best thing for any patient.
Yeah, absolutely. So at least, as you mentioned, there is a focused effort to find the evidence for best treatment for these patients. And this is one of the sessions, for example, SCAI, when they sponsor these sessions, because they want to make physicians aware of what is up to date from experts like yourself, but also to brainstorm new ideas how to move forward.
Yes, absolutely. The session I did this morning, which was focused on DVT, was that John George ran. It was really spectacular, actually, talking about how we should approach DVT, which is, of course, the precursor for pulmonary embolism, and what's the best treatment modality, and whether people should be treated or not in light of the NIH trial that showed there's some concern about treating all patients. So we need to refine all of these things and learn more about all of the conditions and the individual patient conditions, and then specifically which patients qualify for treatments, and then how well do the new modalities work. I mean, there's a huge amount of investment in industry and physicians in trying to develop new technologies. I believe that we're going to be in a different space completely in about 10 years.
Absolutely, yeah. Thank you, Dr. Rosenfield, for your time. Really insightful interview and a lot of information. Watch this interview and others on SCAI-TV YouTube channel. This is Alraies from SCAI 2022. Thank you so much.
Thanks, Jadi.